Hello, I'm Sue Popkin, Institute Fellow and Co-Director of Urban's Disability Equity Policy Initiative, or DEPI, which launched last year with support from the Ford Foundation's Disability Rights Program. I am an older white woman with salt and pepper hair, and I'm wearing glasses and a black and white patterned jacket. I'm going to start with some housekeeping as people are joining. We've already had a question. The event is being recorded, and the recording will be posted online afterwards, along with the report that we'll be discussing today. Speaker biographies and slides are available online. You can hide captions or adjust settings with the Hide Show Captions button. All participants are muted, but you can type your questions or comments into the Q&A box at any time. And please take a couple of minutes at the end to complete the survey. And lastly, engage with us online with the hashtag #LiveAtUrban. I'm very excited to welcome you to DEPI and Urban's first ADA anniversary event today. I'm going to give you a little background on DEPI. We launched last year and are working to build a body of evidence to improve the lives of disabled people. DEPI's goals are to encourage researchers to bring a disability lens to their work across the Urban Institute, conduct research that will inform policy, and elevate the expertise of disabled researchers. Today, we're going to be talking about long COVID, which is a new form of disability. HHS defines long COVID as signs, symptoms, and conditions that are present a minimum of 4 weeks after the initial infection. They may be multisystemic, and they may present with a relapsing, remitting pattern, progression worsening over time. Long COVID affects at least 1 in 10 people who have had COVID-19. There are other autoimmune and post-infection conditions that share some of these characteristics, like chronic Lyme, ME/CFS, and the illnesses I live with, Sjogren's disease and dysautonomia. All of these conditions are disabling, are poorly understood, and lack effective treatments. Today, we are going to discuss some of the challenges of living with long COVID, the need for more and better research to understand these conditions, and the need for policy to ensure that people with these conditions can access government benefits. And now we're very excited to have with us today Meghan O'Rourke, the author of The Invisible Kingdom, who's going to kick us off with a conversation with my colleague, Myra Jones-Taylor, Urban's Chief Policy Impact Officer. Looking forward to a great conversation.
Thank you, Sue, and welcome, Meghan. Welcome to everyone who's joined us. I'm Myra Jones-Taylor. I am a Black woman with big curly hair. I'm wearing a bluish-green top and a pop of red lip. Meghan, I'm going to hand it over to you, and then I'll kick off with some questions.
Hi, everyone. I'm Meghan O'Rourke. I'm a woman in my 40s. I'm wearing glasses, and I have dark brown hair and a kind of, I don't know what to call this, colorful dress. Yes, purple and pink dress.
Great. Well, Meghan, you wrote quite the book, New York Times bestseller. It is, the best book of 2022, according to the New Yorker, Vogue, many others that I'm forgetting, and of course, a finalist for the National Book Award for Nonfiction. So congratulations, and thank you for this incredible body of work. I would love for you just to kick us off by telling us a little bit about the title, Invisible Kingdom. What does it mean?
Absolutely. Thank you so much for having me. I'm beyond excited to be here today to speak with all of you and our amazing panelists who are coming. So The Invisible Kingdom, funnily enough, this was the last part of the book to come into focus. I had a totally different title that I was dissatisfied with. And the reason I was dissatisfied with the original title was that it was a little bit vague and maybe a little bit melancholy seeming, or just, I don't know, not quite speaking to the full reality of the lives of people with chronic illness and disabilities. And I wanted to find a title that spoke to both our experience in an image that could evoke what it's like to live with so-called invisible illnesses, but also, I don't know, have some element of hope in it, right? And so as I was sitting there thinking, what could this be? What could this be? I was thinking about an amazing quote from the writer Susan Sontag, whose book Illness as Metaphor is a kind of godparent to my book. It's a book about how when we don't understand an illness, we tend to stigmatize and psychologize it rather than look for the biomedical realities of it. And she has an incredible quote, which is about the fact that all of us live in both the kingdom of the well and the kingdom of the sick. And at some point in our lives, though we may not wish to, we're going to have a passport that takes us to the kingdom of the sick. And in that moment, rereading the quote, it came to me that, really what I was writing about was this invisible kingdom of people. And that as alone as I had really felt when I was at my sickest, and the book chronicles that sense of loneliness, I was actually part of a much larger movement of people looking for validation, research, coming together in search of answers, and that there was hope in that idea of the invisible kingdom. Alone, we might be easy to ignore, but together we come together to make change, I hope.
I love that. Thank you for sharing that. So let's dig in a little bit here to the topic at hand. If you could tell us a little bit about just describing what the issues facing people with invisible chronic illnesses in our country's medical system are. Just describe them for us. Give us a flavor for what that looks like and feels like.
I'll try to be brief.
No, take your time.
Because we could spend all day talking about this. So the book tells my own story of getting mysteriously, I wouldn't even say mysteriously ill, but ill in a way that no one understood when I was about 21. And it chronicles, I think, my own journey from looking for a kind of very clear-cut answer and treatment to a place that I think many of us are today, certainly those of us living with infection-associated illnesses, in which we have a much more complex understanding of the body and the interrelationship of systems. Okay, I'm telling you that by way of getting to your question, which is, though I got sick at 21 and started actively looking for answers about what was going on with me, it was not for more than a decade. It took more than a decade to get any kind of diagnosis. And in that time, I was actively seeing healthcare providers of different sorts, specialists, research specialists, going to academic medical hospitals, and just getting nowhere and no answers. And commonly what happened was that doctors would take a history, do some tests, and when the tests didn't find anything concrete, although they did have little strange anomalies, they would start asking me about anxiety. And they would start saying, well, you have a really intense job. I was an editor at the New Yorker magazine at the time. And they would say, well, maybe, you're not sleeping enough. Let's give you sleep medication. Let's give you, maybe you should see a therapist. So what I found in my own experience that was then borne out in the reporting I did as a journalist in the Invisible Kingdom was that people with what we're calling infection-associated chronic illnesses, let's include, ME/CFS, post-treatment Lyme disease syndrome or chronic Lyme, now long COVID, among many others, autoimmune disease and much more, are facing what the journalist Myra Dusenberry calls in her book about women's health, both a trust gap and a knowledge gap, which is to say, when we go to doctors, because our conditions aren't well researched and clearly delineated, because they're multisystemic, we're seen, when tests don't show clear answers, we're suddenly turned into unreliable narrators, right? I remember feeling quite distinctly that nothing I said mattered because I had been kind of dismissed as a witness in my own case, right? That in fact, the more I protested, the more dismissed I was. So there's this kind of trust gap. And I think the trust gap really emerges from the knowledge gap, which is to say these conditions are profoundly under-researched. And alongside that knowledge gap is a kind of structural problem, which presents an enormous barrier to care. There's many structural problems, but key among them is the fact that we live in a really siloed medical system that has many specialists who are not always trained to talk to one another. And it can be very hard to get lab work from doctor to doctor. It takes incredible initiative, financial resilience, ability to take time off from work to go access all these specialists. And in my own case, I found that I had to be the connector among them. And at one point in the book, I calculated how much time it was taking me. And I think it was something like 5 out of every 28 work days I was spending at doctors' offices, trying to get answers, and then at home calling the doctors to get labs transferred from place to place. So that barrier to care is really baked into the kind of bureaucracy of medicine. The very last thing I'll say on this front, although there's more to dig into, is that when we think about the knowledge problem, part of it comes from the fact that we live in an era of evidence-based medicine, right? This has brought us our longer lives. This has brought us better treatment. This has brought us with it, hopefully, more care about patients' rights. But along the way, strangely, the pivot to measurement in modern medicine meant that if there are things we don't yet know how to measure, questions we don't yet know to ask, and the answers come up blank, the patient living with an illness that is at the edge of medical knowledge gets turned into this unreliable witness, right? So it's this kind of perfect storm and circle in which the more you're tested and the more you don't know, the more unreliable you become. I hope that makes sense.
Oh, it does. And it's harrowing just to listen to, and I can imagine the experience of it, and knowing that there are so many more than your one profound story is even more troubling.
Yeah.
So tell me a little bit about long COVID. You mentioned long COVID, and I know that you are now writing a little bit about this. So tell me just why did you start thinking about long COVID?
There's two answers to that question. So the first answer is that as I kind of obsessively read the news in January of 2020, I remember thinking, okay, this is a pandemic, it's coming our way. And I very distinctly, because I was deep in the writing of The Invisible Kingdom, and I was reporting on the fact that there's a kind of avant-garde group of researchers who were really making headway into the idea, showing clearly in their research that though we once thought of germs and pathogens as things that kind of came into the body, acted similarly from person to person, and then you either succumb to the pathogen, right, you die, or you overcome it and you move on. That was the idea of germ theory. Built into the germ theory of the 19th century is this idea that pathogens behave very similarly body to body, produce very similar symptoms. That's one of Koch's postulates. So I was sitting there in January 2020 writing about this and writing about researchers who were saying, no, actually, we think we got this wrong. We actually think that in a significant portion of people who are either genetically susceptible, environmentally susceptible, or susceptible because due to psychosocial stresses, social stresses, there's, maybe in many cases, people who just don't get fully better and in whom pathogens like Epstein-Barr virus might go on to trigger a long-term illness, as we've now seen it does for multiple sclerosis, for example. There's a really clear a study came out last year showing a connection, right, between Epstein-Barr and multiple sclerosis. Okay, so why am I telling you this? Because I was sitting there on my couch thinking, oh my God, this pathogen is coming. We don't know anything about it. And people are acting as though the news media is telling us a story as though like, it's really just going to affect people who are older. And if you're younger, you don't have much to worry about. And I sat there thinking, actually, young people may have quite a lot to worry about because they might get this pathogen and never recover. And that's the rest of their lives, right? So I started lurking on message boards on Facebook and elsewhere, sort of waiting to see if anyone was reporting getting COVID and then just not getting better. And pretty early, I started seeing accounts like that. And I began in, I think, May of 2020, reporting what became a pretty early piece of journalism on long COVID for The Atlantic, a long form article about the scope of the problem, the seriousness of it, and the fact that we really were facing a healthcare crisis that might lead to a mass disabling event and that we really had very little understanding of. So that interest at that point, I think, was one of, was kind of fraternal, right? It was like I'd been through this and I could imagine that others soon would be going through the special kind of hell I had lived through. And then, of course, I would say it was almost exactly a year ago after my book came out, I actually got COVID-19 and now have long COVID, which I suppose I could have predicted would happen, in part because there is an interrelationship among some of these kinds of infection-associated illnesses. And so now I think, it hasn't changed my relationship to it so much. I mean, I already felt quite passionately that we had to advocate for people living with long COVID. We had to create a social system and a governmental structure that supported long COVID. And now I think, having lived through it and seeing my son, who also has some long COVID symptoms, I feel, of course, more passionately than ever that we need to focus on this. But in a way, it's not even the personal piece that matters to me.
Just really helpful to hear from you. Not helpful, but gets to my next question. So there's the personal element of this, but what I'm hearing from you, there's a broader interest in making sure that fewer people suffer. And I would just love to hear from you what you're hoping will come of the push for more research and better treatments for long COVID.
Yeah, I think I have multiple hopes, right? I think one thing that can be infuriating, if I can use that word, to many of us living with infection-associated chronic illness is that there's just so much low-hanging fruit, so many interventions we could make societally and in terms of medical education that would dramatically improve the lives of those of us who live with infection-associated conditions. And we just need to come together and show the social will to make those changes. So I feel both that we really need to have this conversation about long COVID specifically as a specific condition and disease and syndrome, and look at what its pathophysiology is, treatments, rehab. And we need to use the energy around long COVID and the funding around long COVID to bring along other diseases that have long been stigmatized and marginalized, among them chronic Lyme, which is itself a hugely contested term that, you know, many people would lambaste me even for using as a journalist, ME/CFS and more, because there is a lot of research suggesting an interrelationship among these things. And for example, many of the people with, chronic Lyme or post-treatment Lyme disease syndrome I've interviewed have a condition known as POTS. I myself had it, triggered by Lyme. That also shows up in long COVID, right? Some people with Lyme seem to have this kind of hypercoagulable, I can't even say the word, blood, right? We're seeing evidence possibly of microclots being a driving factor in long COVID. The point being, there's this kind of interconnection. People with Lyme disease, ME/CFS, there's sometimes recurrence of viruses. We're also seeing recurrence of Epstein-Barr virus in some cases of long COVID. So, what's been really interesting to me as someone who's lived with these different conditions now for more than 20 years is that my long COVID feels quite like what I was living with before, but it is distinct, right? And yet it's not totally distinct. So I have a really deep hope. I think there's a real need for identifying interrelationships among these diseases. And then there's a profound need for quick action on medical education. This to me seems like one of the lowest pieces of we could do this, right? Like educating ER doctors to screen for POTS, postural orthostatic tachycardia syndrome, explaining the pathophysiology that we currently understand around long COVID. Okay, we don't know everything. Here's what we know. Just getting much more information out there. Second, and I know we'll talk about this on the panel, we absolutely have to commit to social support, disability aid for people living with long COVID and these illnesses. I'm just hearing from person after person I interview about how hard it is to get any kind of support, right? So there's both these barriers to care that should be there that we need to fix and we can fix, I think some of it at least. And then there's the barrier to support, like not having adequate support to continue to live your life and put food on the table and try to work if you want to work. Many people want to work and are finding it's hard to get accommodations. So these are the areas I think are really, really important. We also need, and this pre-existed long COVID, more centers that deal with autoimmune disease, infection-associated chronic illness, diseases of the immune system, just as we have cancer centers. So that's a lot, but I think that encapsulates, I'm sure I forgot 5 things that I also feel we deeply need, but I think those are some of the most pressing on my mind right now.
Yeah. And, I really appreciate you kicking this off with the question, can you even use the word infuriating or infuriated? And I think absolutely. And we know that change comes when people get angry and get so 100%. And we're going to hear from some more folks later in the panel to think about how we turn this energy into action. But I want to ask another question here about, this idea that people with chronic illness often aren't believed. You spoke about the trust gap, and it's blamed on hysteria or body weight, all kinds of things. And in this case, with long COVID. And I would love to hear you surmise, I guess, if you think COVID is even more stigmatized because of misinformation around COVID. So this kind of vicious cycle that people don't sometimes. Many people didn't even believe that COVID was a thing, right? Or that's something that was dismissed or diminished in many people's minds. And then we have this idea that no, it's not going away. It's still here. In fact, it's quite devastating for 1 in 10 people who have it. But if you have this stigmatization that's happening, how do we really think about unpacking that for people who have long COVID?
Yeah, I mean, I clearly long COVID is deeply stigmatized, right? I don't want to get into like which is more I know you're not really asking me that.
No. Yes.
More stigmatized, right? Because we have Lyme disease deeply stigmatized. ME/CFS deeply stigmatized. But I think what's really interesting and an important challenge for all of us who are doing advocacy and research in this space is to think about, and this is the part of me that's not just a journalist, but that's like a poet, we're supposed to see into the human psyche. I don't know whether we do, but we're supposed to really think a lot. I'm kind of haunted, in fact, by this question of why is it so hard for people to credit the reality of these diseases, right? Why, in the face of emerging science that's pretty suggestive and also paints a pretty consistent picture of possible avenues of dysfunction, why do people still really want to believe this is psychological in nature? I was just at dinner with a really brilliant writer, doctor, who just immediately was saying, oh, this woman came in and, I could just tell it was, hysteria. And I mean, my like nerves constricted in the back of my body. I guess that sounds sort of hysterical. But, I just thought, well, this is really interesting. This is a very educated, very open-minded person who's experienced quite a lot in his life. But there's something about the medical education system and something about being confronted with uncertainty and seemingly vague, nebulous, multi-systemic illness that just pushes us right to that place of this can't possibly be real. And I think it's crucial for us to both look at, there's this kind of, I think, almost universal human impulse to try to reassure ourselves when we're faced with very, very scary realities. And I want to be clear, long COVID is a very scary reality. ME/CFS, terrifying. Lyme disease, terrifying. My children are at camp right now, and I'm like, right, they could just come back with a tick bite that means they might never get better. It's possible, right? We don't know anything about these diseases. They're affecting healthy young people, and they're powerfully debilitating. So I think healthy people, just kind of lacking a framework, want to just be like, it's going to be fine. Then overlaid on that is what you're talking about, which is a whole kind of program of political misinformation, anti-science thinking, and the ways in which COVID in particular kind of hits this nexus of, it's become a kind of shibboleth in the culture wars, right, in the political wars. And so the right has really weaponized COVID. They wanted to go back to, normalcy as soon as possible. And so long COVID was an uncomfortable reality. In the midst of that, it had to be minimized in order to make the case that we could all just resume as normal. And I think now, in a way, for everybody going back to normal, there's a cognitive dissonance. If they really stop to think about how pervasive long COVID is, how debilitating it is, and how little we know how to prevent it or treat it still, it's terrifying, right? You can't really go back to life knowing that. So I think that there's both this political misinformation campaign and a very powerful thing we have to overcome, kind of in terms of the politics of America. And then there's this kind of human piece we have to overcome, which is everyone wants to go back to normal, and long COVID is an inconvenient truth, to borrow Al Gore's climate phrase.
No, absolutely. One thing I really want to dig here, but we don't have enough time. I just think it's this fascinating connection between this fear of the unknown and the reaction to reject. And then they're thinking about how society is called upon to protect the people who are unknown and are stigmatized, right? So if we think about if long COVID does exist, then that means we actually need to be thinking about the protections of our colleagues. I think about colleagues of mine at Urban, who, I think we do a good job of making sure we keep our masks on if someone in the room has masks, but this is also asking something of people who would rather forget, rather move on. So there's a real tension there. But I do want to ask you maybe one final question here. We've spoken about, rightfully so, about so many of the challenges and the things that we really need to work on. I do wonder if there have been any, I don't even want to say positive, because I don't think anything, I never look for a silver lining in crisis. I don't think that's helpful. But we have seen there's been an increase in telehealth. There's been an increase in remote work that obviously will protect people who are more vulnerable to disease and illness. I'm wondering if you could talk, if you think that long COVID will bring about any positive developments in society. Not that it has to, because we don't have to have positive things come out of crisis, but if you have any thoughts there.
Right. None of us want to be in the business of being falsely optimistic, right? But,
Sure.
and I have thought this from the beginning, and I have had highs and lows thinking about this, but I will tell you where I am now. I do think, and my reporting is suggesting to me, that the scope, in fact, the actual scope of the tragedy of long COVID, and the fact that one of the things that distinguishes long COVID from, let's say, ME/CFS, is that there's a very clear, visible onset for the first time, and we can attribute it to one pathogen, means that there has been a scientific will to study this pathogen in a way that, and its long-term effects in particular, that didn't really exist there, and there's funding for it. So where there's funding, there's hope. There is funding. What I'm also seeing is that, because again, it really is hard to ignore. I know many Americans are ignoring it, but for some researchers, some truly open-minded, curious scientists, it's very hard to ignore the visible evidence of this pathogen coming through, causing an acute wave of pandemic and causing multiple chronic waves of pandemic. They're really asking themselves questions for the first time about Lyme disease, about ME/CFS. And just a few weeks ago, I was in Washington at a conference at the National Academies of Science, and NASEM, I'm going to forget the name because that's part of my long COVID, is I can't remember any details, but it was about, it was a workshop about infection-associated chronic illness, and people were talking about Lyme and ME and, long COVID all together. And I'm not kidding when I tell you that in 2013, 10 years ago, when I was at my sickest, I was pretty much bedbound, and I would lie in bed and I would literally fantasize that someday there would be scientists in a room talking about people like me, and I would know about it, and I would feel that sense of hope. Because I think that one thing, a human reality we have to attach to the research that's going to be discussed in a few minutes, is that these are facts and numbers that are being described, but behind the facts and numbers are human lives. And every human life, almost all of us, experience some kind of limitation or accommodation at some point. But the tragedy is when that accommodation or limitation is rendered meaningless, right? When you're dismissed for the very identity you have. And so I really do hope that this new science and this kind of will and energy and funding is going to help people like me, 10 years ago, where I just felt my case was meaningless because no one cared, no one was listening, no one was researching. And although I know so many patients and people with long COVID who feel this way today, I am seeing these glimmers of research starting to come together to tell a story. And I really think when that science is done, a lot will change. And through the work of places and conferences like today, where we're talking about, okay, what are the needs around the ADA? What are the needs around healthcare? How do we talk about healthcare barriers? How do we actually concretize the problem and start to overcome it? I do feel like some sense of hope. That was a long answer.
It was a great answer, and I really appreciate your contribution to this issue. I can't wait for the next body of work to come out, the next book to come out, and I'm so glad we get to engage you in the next two sections from now. So, and I just want to also just tie in something that you said about the science and the research, which is why Urban exists, is so we can take the data, think about the evidence and think about the solutions that will make people's lives better. And so we are in this fight. That's why Depi is doing this work. My colleagues are doing this work, and I'm so grateful to you for doing it, and really pleased that we can contribute to this. conversation and this work, and hopefully people will be better off. So Meghan, thank you so much. And now I'm gonna, we'll see you in a little bit again. And now I'm gonna introduce you to another colleague of mine here at Urban, Michael Cartman. And Michael is a principal research associate in the Health Policy Center here at the Urban Institute. His work focuses on the implications of the Affordable Care Act, including quantitative analysis related to health insurance coverage, access to and affordability of healthcare, use of healthcare services, and health status. Michael, I am thrilled that you can join us and share with us some of your latest research on this issue.
Thank you, Myra. Hi, everyone. I'm Michael Cartman. I'm a white man in my 40s. I have light brown hair and I'm wearing glasses and a blue shirt. I'm going to present new research findings from a research brief on experiences with employment and material hardship among people with long COVID. This study is based on national data from an Urban Institute survey that we conducted last December. And I'd like to acknowledge my co-authors, Olivia Fiel, Sue Popkin, Elaine Waxman, and Sadie Morris from the Urban Institute, and Lisa McCorkle from the Patient-Led Research Collaborative. Next slide. I'd also like to acknowledge the Robert Wood Johnson Foundation, which provided funding for the research and for the Wellbeing and Basic Needs Survey, which is a nationally representative internet-based survey of approximately 7,500 adults ages 18 to 64 that Urban has fielded annually since 2017. The survey samples drawn from the Ipsos Knowledge Panel, which is an online research panel that includes people with and without household internet access. The December 2022 round of the survey included a series of questions asking respondents whether they ever had COVID-19, if they were currently experiencing long COVID symptoms, and the impact of those symptoms on their employment. Next slide. Overall, 58% of adults in our sample reported ever having COVID-19. Most of these adults received a formal diagnosis from a healthcare provider or had a positive test. But our analysis also includes some people without a diagnosis or positive test who thought they had COVID, which helps us avoid understating the share of people with COVID-19 because of a lack of access to healthcare and testing, as well as limitations on the accuracy of tests. So overall, among adults who ever had COVID-19, nearly 1 in 5, or 18%, were experiencing long COVID symptoms at the time of the survey that had lasted 4 weeks or more, and most of them had symptoms lasting for at least 3 months. So overall, about 10% of the adults in our sample reported long COVID symptoms last December. Next slide. The population of adults with long COVID was disproportionately composed of women, Hispanic or Latinx adults, and adults with disabilities. This is consistent with other studies and surveys showing certain groups of people with COVID-19 may be at greater risk for long COVID, including those who are female or who have pre-existing chronic conditions or disabilities. In our sample, nearly 4 in 10 adults with long COVID, or 38%, reported a disability. The higher rates of long COVID among Hispanic or Latinx adults could reflect greater exposure to COVID, including before vaccines were widely available, in part because of their higher rates of employment as frontline workers. Next slide. So overall, we found that 1 in 10 adults with long COVID reported that they stopped working for a period of time because of their symptoms, including 5% who were not working at the time of the survey and 5% who were employed. Another 5% reported reducing the number of hours that they worked at their current employer. But by far the largest response was to limit activities outside of work, such as social activities, errands, and chores at home, in order to be able to continue working. Nearly 1 in 4 adults with long COVID reported limiting their activities for that reason because of their symptoms. This could partially reflect a lack of paid leave at work. We found that workers with long COVID in our sample were less likely to have access to paid sick leave and medical leave at their jobs. Some relatively less common responses included changing employers to find one that could accommodate people's illnesses, or requesting a reasonable accommodation at a current employer. Next slide. So this chart shows employment rates for three groups. The first is adults reporting long COVID. The second is adults who ever had COVID-19 but did not have current long COVID. And the third is adults who did not report ever having COVID-19. And so you can see that adults with long COVID were about 11 percentage points less likely to be employed at the time of the survey than adults who had COVID-19 but who were not experiencing long COVID symptoms. 65% of adults with long COVID were working versus 76% of adults with COVID-19 but not long COVID. Adults with long COVID were also twice as likely as that group to be out of the labor force because of health reasons or a disability, 11% versus 5%. And it's also just worth noting that the third group in this chart, the adults who did not report having COVID-19, may include some people who are misclassified because of a lack of access to testing or other health care. Next slide. So we also compared these three groups based on their experiences of material hardship in the past 12 months. We found that over 4 in 10 adults with long COVID, 42% experienced household food insecurity in the past year, which was roughly twice the share as other adults. This percentage includes adults reporting low or very low food security. 1 in 4 adults with long COVID, about 25%, reported very low food security, which is a more severe situation in which people reduce their food intake, such as skipping meals. We don't know the extent to which these disparities can be attributed to long COVID. People who are at greatest risk of developing long COVID also faced higher rates of poverty and financial difficulties before the pandemic. And long COVID could have caused new challenges or worsened existing hardships through its impact on people's ability to work and carry out daily activities, as well as through an increase in healthcare costs. Next slide. We also found that 1 in 5 adults with long COVID reported problems paying the rent or mortgage in the past year. Nearly 1 in 4 had problems paying utility bills, in this case, gas, oil, or electric bills. And almost 1 in 10 experienced a utility shutoff in 2022. And so, in each case, these hardships were reported roughly twice the rate or more compared with other adults. There's been a great deal of research showing that these kinds of social and economic factors have a critical impact on population health, even more so than medical care, because when people can't afford to meet their basic needs, they have much greater difficulty recovering from illness and are at a much greater risk of poor health. Next slide. But medical care is important too, and there's a pressing need for research on effective long COVID treatments and guidance for healthcare providers, as well as health insurance reforms. A previous Urban Institute survey that we conducted in June of 2022 highlighted some of the healthcare access and affordability challenges that adults with long COVID have faced, including being more likely to have unmet needs for healthcare because of the cost, having difficulty finding providers who would see them, and getting their health plans to pay for care, as well as more problems with medical bills and medical debt. And these findings were recently published in an open access journal of the American Medical Association. Next slide. So to summarize our findings, we found nearly 1 in 5 adults with COVID-19 and 1 in 10 of all adults ages 18 to 64 in our sample reported long COVID symptoms as of last December. Nearly 4 in 10 of those adults had a disability. Long COVID symptoms affected employment and work hours for many adults, and many others limited other types of activities in order to keep working. And we found stark disparities in material hardship and difficulty navigating the healthcare system and paying for care. Like all surveys, there are limitations to our data, including non-response and measurement errors, but the patterns that we found in our study highlight the broad scope of the challenge and the need for a holistic approach to long COVID, including ensuring that people can access key safety net programs, expanding access to paid leave at work, and making workplaces more accommodating. And our research brief describes these policies in more detail, including improving safety net access for people with long COVID and other people with disabilities, for instance, by reducing burdensome application and documentation requirements and ensuring eligibility criteria based on disability are inclusive of those caused by long COVID. And so with that, I'll turn it back to Myra.
Thank you, Michael, and thank you for your work and the work of our colleagues at Urban for that not very uplifting, but very informative study. Thank you. So now I'm going to introduce our panelists to the conversation. I'd like to have them join. Lisa McCorkle is a person living with long COVID and the co-founder of the Patient-Led Research Collaborative, a group of long COVID patients conducting research on long COVID and advocating for better policies for disabled people. We also have Nisha McCrae, who is the Director of Education for the COVID-19 Long Haulers Advocacy Project. Sorry, dogs in the background. And Executive Director of a nonprofit organization, Bajika, which was born out of MIT. Her work focuses on making STEM, science, technology, engineering, and mathematics education accessible to learners of all ages and backgrounds. And I'm also very pleased to welcome back my colleagues, Sue Popkin and Meghan O'Rourke. Welcome. So thank you all for joining this conversation. And Lisa, I'm going to start with you. At a time, and we've touched on this a little bit earlier, but at a time when many people have moved on from the pandemic, the evidence presented today makes clear that people with long COVID are bearing substantial health and economic costs. So what policy changes could help reduce these costs?
Sure. Thanks, Myra, and thanks for having me. So there's so many policy changes that we need. So I have a lot of thoughts on this because what we need really ranges from changes to the social safety net, to changes to healthcare, to work, to treatments. And I think an important point to mention that Michael touched on is that people who are more likely to develop long COVID are already marginalized populations often. So these are communities of color, people with lower incomes who were already bearing substantial health and economic burden. So when we're looking at policy solutions, we need to recognize that the current social safety net that we have is not helping people meet their basic needs and address social determinants of health. And then when you add in the now over 15 million adults and millions of children who have developed long COVID over the last 3 years, with 42% of them having food insecurity, 20% having difficulty paying rent or mortgage, our numbers growing daily, especially with reinfections, we really need drastic changes to our system in order to address this issue. And I also want to be clear that many of the policy changes that we need are not unique to long COVID. We need a more robust social safety net in place for all disabled people. The programs that we have now, SSI, SSDI, SNAP, TANF, Medicaid, utility and rental assistance that are in place to help people have so many barriers to access. So removing those barriers is one first step. So what that could look like is simplifying application processes, removing or at least updating asset limits. The SSI Savings Penalty Elimination Act would do that. We also need it to be easier to apply for Social Security disability benefits. 85% of people who apply on their first round get rejected. So we need to address that. At minimum, provide free legal assistance to folks to help them through that process. And even if you get on those benefits, it is very difficult to meet your basic needs with that level of income. It's really just not enough money in order to survive. And then for other programs that consider disability and illness in their eligibility determination, so things like utility assistance, even like SNAP work requirements, too often for chronic illnesses like long COVID, it's really difficult to get approved for those because people lack the proper medical documentation because of the problem of having basically no or limited access to healthcare. And then, so then if you turn to the healthcare side, that comes at a huge cost. There's a lot of barriers. Meghan touched on this a lot, as did Michael. I think health is a human right. We need universal health care. We need massive provider education on these conditions, and we need more community-based options that provide wraparound care and treatment to folks. And then we turn to work. We need better and more enforced, reasonable accommodations. Accommodations need to be normalized at work. Things like flexible schedules, working remotely. We need universal paid leave so that if people do get sick, they can rest and not get their coworkers and community sick. And so that folks can actually focus on resting and not worrying about if they're going to be able to pay their bills. Another thing is that we still need to try to prevent transmission of COVID. Reinfections significantly increase your risk of developing long COVID. So if we're talking about policy changes that help reduce the cost of long COVID, we need to be looking at reducing cases of long COVID as well. And of course, we need treatments. So we need more funding for clinical trials. We need more research into long COVID and other infection-associated chronic illnesses. And then once we have those treatments, we don't stop there. We need to make sure that those are equitably distributed.
Thank you, Lisa. I hope everybody was taking note. You just listed off all the policies we need. As someone who spent a lot of my career focusing on paid leave, I want to double down on that. And you also mentioned, the lack of benefits. We have benefits, and even once you get them, are they enough? And I want to just point folks to a recent study that Urban just put out. It's something we put out regularly. It's our SNAP gap map. I know there's a better name for that, but that's what we call it internally. But if you go to our website and look up our SNAP information there, you can find out just how far or how not far our SNAP benefits go in this country. I'm going to ask you another question, Lisa, before I hand it over to Nisha. So Nisha, you're on deck next. But Lisa, just want to ask you one more question. So 1 in 4 people with long COVID reported that they limited activities outside of work to be able to continue working. We saw that in Michael's presentation. Can you expand on what this looks like for people?
Yeah, so this is a super important point because I think it's easy to kind of gloss over it, but it really it has super huge implications for people's lives. So when people with long COVID and these types of conditions need to limit their activities outside of work in order to work, the impacts of that are very significant. So folks get home from work or they stop working. At the end of the day, they can completely crash. They need to lie down, they need to rest the rest of the day in a dark room without sensory input. They have exacerbation of symptoms. They have increased cognitive dysfunction, increased fatigue, flu-like symptoms, migraines, tremors. Makes it so that literally all they can do potentially in that day is go to work. They aren't able to cook meals, take care of children, clean, do the necessary everyday chores that we need to do in order to survive and live our lives. And so that work can fall on a caregiver if folks have a caregiver, increasing their workload. It may fall on, or it may result in increased costs for folks. So people having to pay for those services. There are things like in-home supportive services, but first, too few people know that exists, and a lot of people don't qualify for that. And then that's not even talking about, the hobbies and things that people love to do that they want to be able to do for enjoyment. So being with friends, being with family. And so either they can't do those at all because of their symptoms, or they're spending all their energy on work. And so they don't have any energy left to do what they love to do. And what's also dangerous about this is that people are often put in a push and crash cycle. So where they push themselves as hard as they can to work, to put food on the table, to pay their bills, and then they crash. And we know from conditions like ME/CFS, which about half of people with long COVID have, that when you push yourself too much and too often, your condition can worsen, often permanently. So you can go from being mild to being moderate, from moderate to severe, from being able to work to no longer being able to work. So that one statistic really has big implications for both the person's life, their well-being, their quality of life, as well as the people supporting them around them.
Thank you. And I know there are many questions that you might be asked in the Q&A section. So now I'm going to go to you, Nisha. So do these findings on the impact of long COVID on employment and hardship resonate with you? Tell me a little bit about what you're hearing as we have this conversation.
Yes, of course. So from our perspective, as we look at our patient communities and groups, for the past 3 years, what we've noticed is that there's kind of that push and pull, almost like a tragic tale of individuals who are trying to maintain some semblance of their socioeconomic status, or the fact that they want to maintain their standard of living or life as they know it. And it's been drastically changed because of this diagnosis, whether formal or informal. And what I mean by that is change is not anyone's friend most of the time, because as human beings, we're resistant to change, especially drastic change. And the things that I'm hearing from the brief and the findings reflect what we've seen over the past 3 years. In particular, what we're seeing is that a lot of patients have had to change their community relationships, their social relationships, as the first shoe that drops. And slowly but surely, other shoes drop, including their work accommodations may not be fulfilled. They're not able to get alternative educational fulfillment. So they find themselves not able to transition to more remote friendly jobs, especially as the findings found. Most of the individuals who developed LC were those who were essential workers or from already disadvantaged groups who may need to pivot in order to take advantage of some of the things we have post-pandemic as economic or financial options. And I can speak personally that even I have had to accommodate or alter my own schedule in order to deal with my own diagnoses. And so nothing that was in the briefing stuck out to me as groundbreaking. If you've been listening to patients who have a confirmed or non-confirmed LC diagnoses, or anyone who's been suffering from autoimmune diseases. And I think it speaks to the bigger picture that when we look at healthcare in America, we need to come from the perspective of there have been cracks in the foundation for a while, and we have forced people like Meghan O'Rourke has mentioned to fill in those gaps as their own job. Just like we force other individuals, regardless of their identity, to fill in those gaps when we feel underneath our current system, it's not profitable or in our best interest to fill in those gaps as a community. And I think we're now realizing that if we have such a huge group of people afflicted from a single vector or variable that we all can acknowledge was real, maybe this is the point where we get out the submit and we fix those gaps, because now we can see it. And I'll give this little anecdote. When I got sick and I was discussing with my mother, like how I was having to drastically change my life, I think one of the most important parts that came about that was I couldn't imagine it was just me, given how widespread COVID was at the time and as we were going into a pandemic. And I made this reference to my mom that nobody will care until they go to their Starbucks and they realize their typical barista is not fulfilling their order. And that's when they'll realize we have to come together as a community and fix those gaps when it comes to providing a safety net. A couple months ago, I had a friend who was informing me she had to go to Starbucks Frappuccinos in a bottle. And I was like, you don't go to Starbucks anymore? Like, she was a Starbucks girly with the cup and everything. And when she informed me, she's like, well, my barista is no longer there. And when I asked her on Facebook if she was coming back or if she was at a new location, she told me she just hasn't felt well since her last infection. And that was one of the things that made me go, oh, it's happening. Because now that colleague is actually taking like precautions and making sure that she's looking after her team as we move into this new normal. And so for me personally, I'm glad to see in the briefing what I've been hearing. And also think that if you ask people outside of this discussion, they can also validate they're seeing some rumblings even in their own social groups.
Yeah, thank you for sharing that. And you spoke about communities getting together and looking for change or working for change. So I would love to ask you why you started the COVID-19 Long Haulers Advocacy Project. Meghan spoke a little bit about being infuriated. I won't put words in your mouth, but I'm curious if you could talk about the experience there and what your goals are and what you hope to achieve with this work.
No worries. So I didn't find C19 Long Haulers Advocacy Project. That was actually Karen Bishop. So no worries. I did find my nonprofit organization, Bajika, but all that expertise is science communication in order to take really complicated principles and concepts in science and engineering in order to bring ideas to reality that I've done through my nonprofit work I'm able to do through C19 Lab. And one of the things I like to tell people that I'm proud of in my role is that when people do not understand something or there's a big unknown, there's chaos because you're confused and scared and there's a lot of fear. What I love about my role is I can take my experience of helping youth not feel so scared or chaotic, try to tackle fields that don't necessarily reflect who they are or what they appear to be to the general public, and helping people who are battling these various diagnoses or healthcare or trying to figure out what does their new normal life mean, help them find some more sanity and reasoning in the chaos in order to make decisions that are best for them. And so for me, what inspired me to do the work was that I wasn't able to do what I was passionate about because we were locked away. And I wanted to redirect that energy towards something I understood on a very personal level, as well as realize there was a gap in terms of reaching disadvantaged communities. And I knew that was my specialty. So that's kind of what motivated me to transfer those skills.
Great. And if you could tell us a little bit about the goals of the project, what do you all hope to achieve?
So the goal of C19 Lab is in order to make sure that long COVID patients, as well as caregivers and those who are supporting their care and future safety nets and social goals, are able to not be forgotten in the conversation. They're always advocated for, hence the advocacy in C19 Lab. Because one of the things we've known is that we stand on the shoulders of giants. So we understand other communities of post-infectious diseases or anything of that matter, that once the spotlight fades, will there still be support or care for these communities? So our goal is to make sure we're in those conversations with government, we're in those conversations in healthcare settings, and we're in those conversations in our community in order to make sure that when there's new policies put in place, whether there's policies regarding housing, access to schools, access to testing, and all of this that has become so instrumental and forefront of our mind the last 3 years. So I think we can all admit we learned so many new rules that occur in our communities thanks to the recent pandemic. We want to make sure that in the years and decades to follow, that those patients are still cared for and are part of the conversation.
I love that. And I'm reminded of nothing about us without us. So thank you for that work. I'm going to go back to you, Megan, and then Sue, I'm putting you on deck. I should have given you the heads up, Megan, but you're a pro at this. But would just love if you could tell us, do you think we'd see, do you think the findings on the impact of long COVID unemployment and hardship, what do you make of those numbers? Probably not too surprising. And you mentioned this a little bit, but if you could talk a little bit more about that.
Yeah, I think not surprising to me based on both my own personal experience and then the reporting I've been doing since the middle of 2020 and talking to a lot of people. And I like Lisa, my previous panel, my panelists have already said so much of what needs to be said, but two thoughts come to me. One is, I, if anything, suspect there's underrepresentation in the numbers in the ways that the briefs themselves allude to. The other is just to not make sure we don't gloss over the realities of some of the kind of knock-on effects of some of these findings. And also, I think very much important to keep in mind that this finding is a moment in time. As someone who's lived with an infection-associated chronic illness for more than 2 decades, the condition changes, your reality changes. And I think in particular, there's kind of can be this snowballing effect of if you don't have access to the social safety net, if you're not getting the disability benefits that you need, if you're discouraged or made despondent by applying and being rejected in the ways that Lisa mentioned, so many people are. If you are functioning at work, but you're coming home and you're collapsing and you're in that push and crash cycle, what is it going to look like 2 years out? What is it going to look 5 years out? What is it going to look 20 years out? What happens to your children? What happens to your job, right? All of those things. And I do think that the human experience of like despair is a really important thing to consider, right? We want people to have hope. We want people to have a sense that that net is there for them. So that's something I think we need to kind of keep an eye on as a reality around the findings. The findings tell us that we have work to do. And because it's the anniversary of the ADA, I wanted to just mention in December, I interviewed the activist Judy Heumann shortly before, a couple months before she died, for this piece that I'm writing about long COVID. And she really emphasized that, if we had already made some of these changes in how we think about disability, if we had already changed not only our built environment, but our mental environments and how we think about disability and how we think about normalizing disability, building it into our lives, we would be so much further along right now, right? And so I do think we need to really keep in mind that we have to figure out the very specific policy changes that need to happen here. We also need to think about how making those policy changes is going to have a positive knock-on effect in changing the whole kind of mental landscape of our society, right? Because people are finding themselves suddenly disabled with long COVID, and their family doesn't know what to do or what to say or how to think. And all too often we'll be like, well, maybe you are suffering from a little bit of anxiety or depression. This just happened to a friend of mine. So I think really keeping in mind the dimensional way that policy interacts with the kinds of narratives we tell ourselves, right, is a deeply entangled reality here, which is part of why the work of like naming these actual consequences in terms of work, et cetera, is so important. And then I think more and more keeping in mind that so often long COVID is hitting communities that were previously marginalized or struggling is just couldn't be more important.
And it's making me wonder, if the findings that we have for long COVID would, how similar they would be to other invisible illnesses. And if you have any thoughts on that, given your reporting, given your own experience and your research.
Yeah, and I think this goes back to legal questions, right? Like we can know that insurance is supposed to cover certain things, but do they? And what are the barriers to care in terms of doing that? And what kinds of in the Lyme community, I have interviewed many people, one of them, a general counsel at a major Ivy League university who couldn't get insurance to cover her Lyme disease treatment. She had every tool in the toolbox available to her, right? She was a lawyer. And so in my reporting, I would say it really bears out that this is not specific to long COVID, but in fact, very true for infection-associated chronic illnesses in general. And it's really a tragedy, right? Because if you also, a nature of these illnesses can be that there are these kind of cognitive effects that are sort of loosely called brain fog, but perhaps a crisp way to describe them is that it can be like having a concussion, right? We all know if you have a concussion, it's very hard to do detailed brain work, like fill out an application, things like this. So this is an area I think we also have to be really mindful about, is how do we support people who are experiencing severe cognitive problems? And also, how as a culture do we change the way we think about excellence and performance to accommodate cognitive challenges, right? Because I actually think that is really important for us. Having cognitive challenges does not mean you can't perform well or have excellence, right? It means different kinds of a performance. This is really important for students. We haven't really talked about children with long COVID, students with long COVID. It's really important for college students, graduate students. So now I'm just losing my thread, but that's another area.
No, so many ways I want to dive into this conversation, but I won't. I will be disciplined. Well, you know what? No, I will. I will ask you if you do have thoughts on, as someone who spent most of my time thinking about young children, my career thinking about young children and families, do you have any contributions to this conversation that focus specifically on children and thinking about school-age children and the challenges that they face? This is separate from work and the findings that we had today, but just any quick thoughts there?
I'll quickly say I'm super worried about children. I'm worried about them for a couple of reasons. I, in my own experience, have had the experience of like not knowing when I got sick, and that really changed the course of my life because I didn't realize I was sick for a long time. And I worry for children that there will be children with long COVID who don't know they have long COVID. I don't want to sensationalize it or say, we really need that research. I think we really need to educate, administrators, educators in what long COVID looks like in children, which might be different from adults. So I think this is a paramount area of concern that we have not in the media had a rigorous and nuanced discussion or representation of, and we need to do that.
Yeah, thank you. Sue, I'm gonna turn it over to you now. So
Jump in on kids for a minute before you ask me.
please, 100%, go ahead, have at it.
So my daughter had long H1N1 flu, post-viral syndrome from H1N1 flu in 2010, I guess, 2009 when she caught it. They had no idea what it was. It is very much like everything that's been described with long COVID. She's in her mid-20s now. She's still living with it. There were no doctors who knew how to identify it. It was very difficult to get help for her. And I could spend the rest of the time we have talking about how badly the school system responded to the situation. And I worry a lot about kids with long COVID and what's going to happen.
Well, there's more research for us to be doing, right, Sue? Well, thank you for that. And thank you for sharing a little bit of your own personal story there. So you and I have spoken about this, about the intersectionality of disability, right? People of color, and heard this from Lisa and others, people of color are more likely to have disability, and disabled people of color are more likely to have low incomes, right? You've done research on this, and then face more challenges with getting care. And there's this kind of cascading effect. Do we know if that's true for long COVID and other complex chronic illnesses like Sjogren's?
Yes. Well, I think we know from what we saw from Michael that Hispanic, Latinx people were more likely to report long COVID. And frontline workers were more likely to report long COVID. I would guess they probably would also be more likely to report they had difficulty getting care. I think that we need to be doing more investigation of that. I know from my own experience, I'm going to tell a story about me again. When we first got involved with Rachel's condition, she has POTS as a consequence of her illness. I have it too, as a consequence of my Sjogren's. The first time we went to a conference of people with POTS, it was almost entirely white women. I don't believe that's representative of the people who have that POTS. I don't think the people who organized the conference thought it was, but I think it shows the access to care, the ability to get a diagnosis and get some treatment. We were able to get our daughter to Johns Hopkins. That's pretty difficult to do. All the things that Meghan wrote in her book about how difficult it was to get diagnosed, but she was able to go to lots of different places to try to find an answer. That's been more my story too. I can only imagine that is not the story for low-income people of color, and that they are probably sicker and probably ending up on disability. And I think that's an issue that really requires more investigation urgently.
So Michael also talked about people with long COVID having difficulty accessing healthcare, as you just referenced. Can you talk about why that happens? And also something we haven't spoken about, well, a little bit, I think actually, Meghan, in your analysis of 5 days out of 28 spent in health, getting care. But can we talk about the time tax as well, and that people with chronic illness face in getting adequate health care? And you mentioned this, but if you could dig a little deeper.
Sure. I think both Lisa and Meghan mentioned this, but in order to be able to get the healthcare you need to be able to find the doctor who will see you, get the appointment, make the phone calls, follow up with the doctors because they don't talk to each other. Even with all these wonderful electronic records, they don't read them. You have to spend the time to send the lab results to all the specialists or doctors who are treating you. If you are a person who has a job where you don't have a lot of leave, where you don't have a lot of flexibility, where you maybe don't have access to a computer during the day or broadband Wi-Fi, I think in rural areas, there must be a huge challenge in getting the care that you need. You can't. You're going to end up with the urgent care or the doctor in the emergency room, and they are not going to know about long COVID or other complex illnesses. And I think often, especially to women, they're going to say, it's in your head, you're anxious, you're depressed, go home and rest. And then the other issue we have is cost. right? There's still a lot of cost involved with getting the care. There are often copays that are prohibitive for people going to the doctor, paying for medications. And if you don't have insurance, if you don't have the ability to pay those copays, then people aren't going to be able to get the care they need.
Something you just said really made me think of the research that we are all too familiar with now around outcomes for pregnant Black and brown people. And so, you know, myself having felt very misunderstood and not listened to, and thinking about that in the context of COVID. And I'm sure that overlay is very clear there. I want to ask you one final question before we go to
Sure.
Some questions and answers from the audience here. We talked about this a little bit, but really want to hear this from you is a good colleague of mine, is how we could make our workplaces more inclusive for people with chronic illness. So what would you say to me? What would you say to our boss? And then how we can help people advocate for reasonable accommodations.
I can mention Judy Human. So I am the founder of Urban Institute's Disability Affinity Group, and I was lucky enough to get to meet Judy Human, who pushed me and cheered me on, both for work making Urban a more inclusive place and also doing the work that we're doing with DEPI. I think we're really proud at Urban. We have a reasonable accommodations policy now. I think it's really important that workplaces have one, that staff know they exist, that they can use them, that they know who they're supposed to contact when they have an issue. I think it's important to be part of orientations and onboarding so new staff know they can ask. And it could be something as simple as an ergonomic mouse, and all the way for people with chronic illness, work from home, flexible schedules, extra time for breaks. And I think those are all the kind of accommodations that people need to be able to be successful in the workplace.
Well, thank you all for this rich conversation with me. Now I get to open it up to our audience and read their questions. And you are going to have to bear with me because I'm looking at this on my screen. So I'm going to field some of these now. So, and maybe I'm thinking, Nisha, maybe you can join in, or Lisa. Are there any chat groups or other patient community groups where patients can trade insights and experiences? And Megan, you also mentioned, you know, lurking on some of those, but Nisha or Lisa?
Sure, I can take it. Yeah, there's some groups that are available. One of the groups that I actually joined at the beginning, Body Politic, unfortunately closed down due to lack of funding and capacity a couple months ago, which I think really shows the importance of funding these very important groups that provide support for folks. But I know C19 Lab, Nisha's group, has Facebook groups where patients share a lot of information. And I can put in the chat a list of other groups that are available. I think especially important to find one that you identify with. There's Black COVID-19 Survivors Group. There's a few different more affinity groups, but it really is those types of groups. The support groups are where I found my most helpful information, and really where I go to first when because a lot of my doctors know less than what the patient community does. So I'll put a link to a few different groups in the chat, and hopefully that can be distributed.
Great. And since you mentioned the medical community and doctors, we have at least one who is listening in and wrote in a really great question. I'll share with everybody and open it up to any of you to respond to. So as a former primary care doc, I would often find myself with patients where the diagnosis was not clear. It was important to be honest with them about the lack of information. In the meantime, though, do you think it is reasonable to offer symptom care, like for sleep, anxiety, depression, pain, etc.? They may be the only solutions we can offer while waiting on the research to catch up. There are huge gaps in our social safety net. And again, these were revealed with COVID, and the fragmentation in healthcare is a national embarrassment. So here we have a physician who is saying, I hear you, and what can we do when we don't know what to offer you? Is it appropriate to offer you this symptom care? Who would like to kick us off?
Could I
Meg-
jump in? No, I want to hear the others too. I'll just say briefly, because I've talked to a lot of people living with illness about this very question. And I will say that many of the people I've spoken to feel, and I myself experience this, feel that it goes directly to the sleep, anxiety, depression, pain. And I think that a really important missing step is something one of my doctors did, where she paused and she said, I completely believe that you have a biomedical condition that I don't fully understand. And she said, I've seen other people like you. I feel very hampered in my ability to help you, which is frustrating for me. You know, she really put us on the kind of same level and took the time to validate and witness what I was experiencing. And then she said, here's what I can do if you think any of this would be helpful to you, right? So that it really became a dialogue about the reality that we both found ourselves in of not knowing, and then went to here's the pieces I can help. The other thing I would say is that I think it's really paramount for doctors to inform themselves about what the emerging research shows, because there are things that can be offered that aren't just sleep, anxiety, depression. And so I think that would show that kind of goodwill and commitment to following the research as it emerges.
Oh, that's great. Nisha, you raised your hand. Want to chime in?
Yes. So one of the things that I've noticed about this hesitancy to do symptom management is sometimes addressing the symptoms while we're waiting for the actual diagnosis or research to catch up is probably one of the most important things to do, as long as you make sure you don't stray too far into the hysteria, anxiety, etc. territory. And what I mean by that is a good portion of my patient history, my doctors were like, oh, it's probably because she's type A, she's an overachiever, that's where all these symptoms are coming from. And I had very serious symptoms that I was dealing with that were life limiting. When one of my actual doctors was able to look and address one of those symptoms, that improved my ability to handle and start tackling the other symptoms by a factor of 3. From simply pivoting from, well, we don't know what it is, to, you know what, I don't know what the overall picture or the umbrella is, but I know this one specific thing. I have a tool in my arsenal that may not be specific to this mysterious umbrella, but I have other patients who this medication or treatment has been helpful. And I think the greatest example could be brain fog. It took me 2 years going through different forums to realize that brain fog is very similar to chemo brain. And once I started going into cancer forums looking at chemo brain, that led to me being able to do my symptom management for my neural inflammation and my cognitive dysfunction. And so even that kind of parallel that you can bring out of your arsenal is so important when you're dealing with patients who a simple symptom management tool can be the difference between working part-time or full-time or maintaining some semblance of their socioeconomic status.
Thank you so much for that. And I'm thinking right now something both, I think, Megan, you said, and Nisha, you mentioned around brain fog and using different terminology. For you, Nisha, it helped you think about different pathways of getting support. And Megan, I think for you, it helped you think about what was really going on. I'm a cultural anthropologist by training, and so language is always very interesting to me, and thinking about the fact that brain fog feels less scientific, right? And it's easier, especially if women are saying it. We know how women are often kind of dismissed in medical settings. So it's really interesting just to thinking about the language that we use and how that can change our interactions, folks' interactions with the medical community. But I did want to just thank the doc who chimed in. It sounds like you're on the right path, and there's more you can do following what Megan said, which is making sure you're current with the research. So thank you for your question. Oh, please, Lisa, please.
Could I add to that?
Absolutely.
Awesome. Thank you. Just wanted to add, I think, long COVID has so much overlap with other infection-associated chronic conditions where we do have, some symptom management techniques. So we've heard POTS today a few times. That's postural orthostatic tachycardia syndrome. That type of autonomic dysfunction is experienced by over 2/3 of people with long COVID. And there are some medications and treatment strategies that folks can use that can really help. Even that's like increasing salt, increasing fluids. And then, as I mentioned earlier, about half of people with long COVID have ME/CFS. And while there's no specific treatment that, that's for ME/CFS, there's a lot of things that help with symptoms. And so what we really need to be doing when we're looking at long COVID and looking at treatments is looking at the existing research on these conditions that's been around for decades and decades. And I think a problem with the current medical system is that these conditions are not taught in medical schools. They're not really focused on as a specialty. And so many providers are unaware of how to treat these. And so that's, in addition to waiting for research to come out, we already have a lot of research on these conditions. We have experience from the patient community on trying different treatments on symptom management. And so I'd encourage doctors in the field to look to the ME/CFS Clinician Coalition, which has treatment options, as well as just listening to and paying attention to the patient community and what we're trying and what's helping us with our symptoms now.
That's great. Thank you, Lisa. So we have time for maybe 2 more questions, and I'm going to tee them up so you guys can be thinking about them. The first is around mental health, and I'll ask that one first. And then the second is around coordination of care. And if we have time, there's one that I think is a really interesting, provocative question. So first, with the mental health, thinking about mental health, and I just lost the question. Here we go. So what are the barriers and burdens that associated with measuring the connection between mental health and long COVID? We've heard that people are dealing with many challenges. We talked about this kind of multidimensional aspect of long COVID, but I'm wondering if folks can talk a little bit about the intersection of mental health and mental health care in relation to long COVID. If anybody wants to chime in. And I kind of botched that question, so if we can move on.
Well, I think it's important that people get mental health care support. I think somebody in our group talked about the despair that comes with these kinds of illnesses. It's real. So I don't think I'm not saying it shouldn't be part of what people have access to. In fact, I think it's very important. But the thing that worries me is physicians dismissing physical ailments as mental health problems, especially when it's a young woman who comes into their office.
Sure.
Or an older woman that happens to.
I'll jump in quickly there to say this is something I tried to talk about quite a lot in the Invisible Kingdom. I think Sue's exactly right. We really have to take care to kind of rigorously disentangle our own assumptions, and also I think get very clear intellectually about how we think about mental health and how we think about biomedical health in conditions that we don't understand. So one of the concerns that I think many patients have is that there can be this almost reflexive categorization of symptoms of something like ME/CFS or long COVID as being driven primarily by anxiety. But as the question gets at, we also don't want to ignore the reality of the intersection of mental and physical health, or the kind of fact that many times there can be an overlapping condition here, right? And further, we can disentangle, the anxiety and depression that come from living with chronic illness, in particular, poorly understood chronic illness, which is a distinct form of depression and anxiety that is well studied. And there is evidence that living with a chronic illness can kind of itself contribute to eventually, right? But I think we have to be very, very aware of our own internal implicit biases, which are to kind of see many of these hard to pin down in medical labs sometimes symptoms as being originating in a kind of psychological problem. And so we use the phrase, Myra, you talked about language. I also think about language. I'm so struck by the fact that we use the phrase, I'm trying to say like psychosomatic. Sorry, that was a brain fog moment. That we use the phrase psychosomatic, but we don't talk about the like soma psychiatric. And I'll just note too that like one of the things that many researchers talk to me about is that in these conditions, including autoimmune disease, where there can be inflammatory processes, those can affect the brain too. The brain is an organ in the body. We still talk about mind body as if we're like Cartesians and many centuries ago, but the brain is there. It's affected by the immune system too. So there can be these inflammatory conditions where you do have an uptick in anxiety and depression, and you have a kind of infection associated chronic illness. And maybe that uptick is actually driven by the biological processes, as we do see in tick-borne illness. So yes, to the question, we need to talk, we need a both and approach, and it needs to be nuanced, rigorous. It needs to listen to patients, and we need to find better ways of disentangling and accounting for our own biases.
Thank you. I'm actually going to skip. I'm going to take the moderator's prerogative, and I'm going to skip the one on coordination of care, because I think there's been a little bit said there. I'm really curious to get folks' thoughts on this. So here's the question. When addressing policy implications, what would you say to someone who says, quote, if we should be supporting all people with disability, why do we need a specific focus on long COVID? Why not just have policies in place for monitoring and supporting disability? So it's an interesting, provocative question, and it's making me think of Judy Human's point initially or earlier. If we just taken care of that in the first place, maybe we wouldn't be in this place. So it's kind of a reversal of that. Any thoughts? If we should be supporting all people with disability, why do we need a specific focus on long COVID? Why not just policies for monitoring and supporting disability broadly?
I'll say something very briefly, because I've been talking a lot, and someone mentioned post-exertional malaise in the comments, which is another frame, and Lisa brought up this push and crash scenario. So clearly we should talk about all disabilities, but I think also we need to, I think we've under-theorized and underrepresented invisible disabilities in some way. I mean, we've underrepresented it all. It's right. We need all boats to be lifted, but there's cultural narratives that we're lacking about invisible illnesses, and cultural narratives that we're lack of understanding, like baseline understanding of the way that these infection-associated conditions can very specifically relapse and remit and lead to bouts of engagement that then can lead to further disability and illness. And I think that's a concept we really do need activism around to get that out in the world.
Lisa, I saw you lean in. Yes, please.
Yeah, that's a great point, Megan. And I think, I said this earlier when I was talking about policy changes we need. I mean, the cracks in our system have existed for a long time. I think what long COVID does is expose them at a really significant scale. But the solutions that will help people with long COVID should also help disabled people generally with improving SSI, SSDI, with improving access to SNAP and TANF and all of these, types of assistance programs that are in place to help meet people's basic needs. But I agree with Megan that I think there is a lack of understanding of a lot of these chronic illnesses and some specific policies in terms of, if you can call like funding centers of excellence for long COVID and related conditions as a policy like that, I think is needed, and just because of the scale of the issue and because of the massive underinvestment in these illnesses over the last several decades. So it's definitely, it's both and. I think the social supports that we need are really ideally for all disabled people, with also an eye towards, how can someone with cognitive dysfunction access an application in order to apply for benefits, right? Like we also need to take a lens of looking at long COVID and these related conditions, and looking at really like all symptoms that someone may experience, and being able to make these programs more accessible.
Oh, there are so many questions in the chat. I wasn't even looking at those, so I just saw the questions in the chat. I am so tempted to ask one final question. I'm going to do it. Something about families. We've talked a lot so if we want to talk about care coordination or families, but I really am curious. Sue, you spoke personally about this. What do we say to the caregivers? And they've been mentioned, but I want to focus on the caregivers in this conversation. Do you all have thoughts? Are there resources people can go to who are caring for those in our community who are suffering from invisible illness and long COVID? Sue?
Boy, that's a hard question for me personally, because I've both been the caregiver and I need help now. I don't think there are. I think there are support groups for patients. But I have certainly there was a group of parents when my daughter got ill. We had a Facebook group and we were corresponding with each other, and that helped. But I think it's a huge need, especially when you're dealing with frustrations with the healthcare system. Your child, as sick as I am now, in fact, when my daughter was sick, it was so much worse. I was so much more scared and upset. And so I think there's a huge need for support for caregivers and for time off to take people to appointments and do all the things that need to be done. Back to the policy issues, Lisa's right. We don't have caregiver leave. So what are you supposed to do when you're juggling your kid's illness and your job?
And on that note, I want to thank each of you for this very powerful conversation rooted in evidence and personal experience and advocacy and beautiful writing. I'm so grateful for all that you're doing, and it is giving me hope. To your point, Meghan, we do need hope, and to know that there are so many brilliant people like you all in this work. I'm getting a little teary-eyed, makes me hopeful. So thank you so much. Have a great afternoon. Oh, and please fill out the survey. There's a survey in the chat. Thanks, everyone. Have a great afternoon.